Hi everybody, welcome to Dr. Manny's Learn Shops. In this presentation, we're going to continue with the adult health assessment, looking at the thorax and the lungs. So when it comes to physical assessment, we have to understand that the thorax and the lungs are vital organs and components as a body structure. The thoracic cavity, the chest cavity, is the space inside your thorax that contains the heart, the lungs, and many other organs and tissues. It's the second biggest hollow space in your body after the abdominal cavity, and the thoracic cavity contains organs and tissues, which includes the respiratory system, the cardiovascular system, the digestive system, immune system, and nervous system. Again, family history is important before doing the physical assessment. History is always important. Questions could involve things like, do you have any family history of respiratory problems? And it's important to provide details. Common conditions and disorders can affect the thorax and the lungs, and these can include things like asthma, bronchitis, pneumothorax, emphysema, cancer fractures, pectus carinatum, pectus excavatum, pericardial effusion, pleurisy, pulmonary edema, pulmonary embolism, and pneumonia. Past history is also important. So questions that relate to the past history could include, have you ever been diagnosed with a condition such as asthma, bronchitis, emphysema, or pneumonia? Did you have any respiratory infections as a child? Do you have any allergies? Have you ever been tested for tuberculosis? And if so, when was your last tuberculosis skin test or chest x-ray? When did you receive your last influenza or COVID-19 vaccine? Medications are again important. So questions could relate to medications such as, do you take any medications for respiratory problems? If so, what are they? Why do you take them? Who prescribed them? Do you take any natural supplements or over-the-counter medications? Lifestyle behaviour. Questions could include things such as, do you smoke cigarettes or have you ever smoked cigarettes, pipes or cigars, or even recreational medications? Drugs. How many packs do you smoke per day? How many years have you smoked? Have you ever tried stopping smoking? Are you interested in stopping smoking? Do you use marijuana, cocaine, methamphetamine, glue, or spray paint? Do you have any hobbies that expose you to paint fumes, wood dust, or birds? Have you recently travelled to any high-risk areas that have known respiratory disorders? Some of the common respiratory signs and symptoms, clinical manifestations, include chest pain or discomfort, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, frequent coughing, mucus or phlegm, wheezing or tightness in the chest, changes in your functional ability related to your activities of daily living. Some of the equipment that could be used when assessing the thorax and the lungs include a pulse oximeter, a stethoscope, a marking pen and small ruler when assessing diaphragmatic excursion. When it comes to the tools and techniques that we use, inspection is one of them. So inspection, initial survey, A, appearance. What's their facial expression? What's their posture? What's their level of consciousness? Are they relaxed in an upright position? Are they alert, cooperative, orientated? Then we have B. B deals with breathing. So you observe the respiratory movements, inspiration-expiration ratio, typically 1 to 2, respiratory rate 12 to 20 breaths per minute, with a regular rhythm. There's no work of breathing, there's no accessory muscle use. If using a pulse oximeter, the SpO2 is normally 95 to 100%. But again, this may be altered if they have some sort of respiratory condition and are typically hypoxic by definition, but which is normal for them. Then we have C, colour. The skin colour is important. You could be pink, dark-skinned, pale, or it could be abnormal in the form of cyanosis or skin mottling. But again, skin colour is assessed according to the appropriateness of tone for the race. Inspection involves symmetry, and we are inspecting the anterior chest. So symmetry, you compare left to right of the thorax. The clavicles and ribs should be symmetrical on both sides. Are the ribs sloping down? Is the trachea and sternum midline? You can be observing for observable deformities, such as masses, swelling, and the shape. Do you notice any deformities or masses or swelling? You observe the costal angle, which is the angle between the costal margins inferior to the xiphoid process. And normally it's about 90 degrees. As for skin colour and integrity, you note, is the skin colour consistent across the thorax? Do you notice any skin discoloration? You inspect the anterior-posterior diameter to the transverse diameter of the thorax. And normally the anterior-posterior, the AP diameter, to the transverse diameter ratio is about 1 to 2. When we look at the posterior chest, we do exactly the same thing. We compare left to right. We look at the shoulders, the scapula and the ribs to make sure they're symmetrical. Does the left and right side of the thorax expand and recoil symmetrically when breathing? We observe the spinous processes for deformities, masses or swelling. So are they in a straight line down the vertebral column? Are the ribs sloping downwards? Do you observe any deformities, masses or swelling? Again, we observe skin colour integrity. Is it consistent? Do you notice any skin discoloration? Are there any scars? Again, we inspect the anterior-posterior AP diameter to the transverse diameter of the thorax, and this is normally 1 to 2. When we palpate the thorax, palpation can be performed with one or both hands. We use the fingers to palpate for tenderness, warmth or pain, or any other sensations. And we start at the top, the apex, and we go to the posterior, the base. We consistently move our hand left to right, comparing findings bilaterally. We always move systematically from top to down, and we even cover the lateral areas of the thorax to determine issues related to the lateral lung bases. When we palpate for something called crepitus, crepitus is also known as subcutaneous emphysema, And when you touch the skin, it's a crackling sensation that occurs when air passes through fluid or exudate in the skin. So palpation for this can be performed with one or both hands. You use your fingers to palpate for crepitus, and you start at the anterior apex to the posterior to the scapula. And you always move your hand left to right, comparing the findings bilaterally. And we move systematically from top to bottom. When we palpate for fremitus, fremitus is different. Fremitus are vibrations of air in the bronchial tubes transmitted to the chest wall. So when we palpate, we can use one or both hands again, but typically we use the ball or the ulnar edge of one hand to assess for fremitus. We start at the apex, top, and we go down to the posterior to the scapula, and we always again move left to right, comparing findings bilaterally, and we move systematically down, and we do cover the lateral lung bases as well. As you move your hand to each area, you can ask the patient to say 99, which is referred to as bronchophony. And we assess all the areas for intentions or the intensity of the vibration. Unequal fremitus is usually the result of consolidation, lung collapse, which increases the fremitus or the vibration. Bronchial obstructions such as emphysema, pleural effusion or pneumothorax all decrease fremitus or the vibrations that you feel. When we palpate the chest, we can also palpate for chest expansion. And this is where we place both hands on the anterior chest with thumbs at the anterolateral wall along the costal margins. And we point towards the xiphoid process, which is the bottom of the sternum. We press gently together a small skin fold, and we ask the client, to take a deep breath, and we observe the movement of the thumbs. When the client takes a deep breath, the examiner's thumbs should move symmetrically, not asymmetrically. Unequal chest expansion indicates there could be atelectasis, pneumonia, trauma, or a pneumothorax. When we assess posterior chest expansion, the hands are also placed on the posterior thorax with the thumbs at the level of T9, T10. Again, we press together gently to create a small skin fold, and we ask the patient to take a deep breath, and we observe movement of the thumbs again. When the client takes a deep breath, the examiner's thumbs should move about 5 to 10 centimetres apart symmetrically. If it's asymmetrical, then you have unequal chest expansion, and this again can occur with atelectasis, which is lung collapse, pneumonia, trauma, and pneumothorax. With auscultation, we're using the stethoscope. And we auscultate for anterior breath sounds, which could be adventitious, and we also assess for voice sounds. So the stethoscope is typically placed using the diaphragm firmly and directly onto the skin of the anterior chest wall. Follow the pattern. We auscultate from the apices of the lungs, which is slightly above the clavicles, to the bases, and till we reach the sixth rib. We ask the client to breathe deeply through their mouth to avoid transmissions of nasal sounds if nasal breathing. You listen at each site for at least one complete respiratory cycle before moving on to the next. Anterior breath sounds are typically of three kinds: bronchial, bronchovesicular, and vesicular. Bronchial sounds are loud and high-pitched. Bronchovesicular are somewhere in between, called intermediate. Vesicular are soft, of a low-pitched quality. When we auscultate the posterior thorax, we auscultate for breath sounds that can be normal or adventitious, and we also use voice sounds. Again, the diaphragm is used, placed firmly and directly on the skin of the posterior chest wall and at the apex of the lung, which is typically at C7. You auscultate the apices to the lungs at C7 all the way down to the bases of the lung at T10. And we also auscultate laterally from the axilla down to the 7th or 8th rib. Again, we ask the client to breathe deeply through the mouth to avoid different sounds that may occur with nasal breathing. And again, we listen for at least one complete respiratory cycle in each place. Always comparing right to left. There are two types of posterior breath sounds. Typically, they are bronchovesicular and vesicular. When we look at breathing patterns, some of the more common breathing patterns are normal, which is regular, without any distress or work of breathing at a rate between 12 and 20 breaths per minute. Ataxic, A means without. So if they're ataxic, they can be irregular. Bradypnea means slower than 12 breaths per minute. Hyper or tachypnea is faster than 20 breaths per minute. Sighing, intermittently, there is interspaced deep breaths. Air trapping may indicate that there is difficulty getting the breath out, and this may result in prolonged expiration. Biot respirations are irregular, and they're interspaced with periods of apnea, which are disorganized. Cheyne-Stokes breathing can be referred to as agonal breathing as well, and there are varying periods of increasing depth with episodes of apnea. Cushional respirations are typically related to diabetic ketoacidosis, but these are rapid, deep, laboured breathing. Tachypnea, we already said, is similar to hyperpnea at a breathing rate of greater than 20 breaths per minute. When we look at breathing patterns, common ones are hypoventilation, which is shallow breathing, and hyperventilation, which is deep breathing. What are some of the anomalies that we might identify in the thorax and the lungs? Well, we have a barrel chest. And a barrel chest is typically associated with emphysema, chronic asthma, or as an overall chronic obstructive pulmonary disease. We have a condition called pectus excavatum, or funnel chest. And typically, this is when you have a depression in the lower part of the sternum, and it's a congenital condition. And typically, it's not problematic, but it could compress the heart and the great vessels, such as the aorta. Then you've got pectus carinatum, or pigeon chest. And this is where the sternum is displaced anteriorly, and this can depress the costal cartilages. It's also a congenital anomaly. Typically, it doesn't cause any issues, but as far as appearance goes, cosmetically here, it may be an issue. And it can be corrected. Another condition is called kyphoscoliosis, or kyphosis, or scoliosis. And this results in thoracic spine curvatures which can affect breathing. We have flail chest. Flail chest is when multiple ribs, 2 or more, are fractured, and this results in paradoxical movements of breathing, meaning that in the flail area, when you breathe in, the chest goes in instead of out. When you breathe out, the chest goes out instead of in, and this can cause problems with respiration. Abnormal breath sounds can be things like fine crackles, also known as rails. Coarse crackles, also known as rails. Wheezes, rhonchi, which are gurgles. There can also be a stridor, which is an upper respiratory tract airway obstruction, which is typically loud, similar to conditions that occur in croup. You can have pleural friction rubs, which are coarse noises that basically occur during inflammation. So if we review, 4 clinical manifestations of a lung or thorax anomaly could be difficulty breathing, abnormal breath sounds such as wheezing, pain, shortness of breath, orthopnea, a cough, sputum or phlegm production, coughing up blood, hemoptysis, and infections. That's the end of this session. Thank you again for attending. If you feel that this has been of any value to you, please recommend it to your colleagues or your friends, and please subscribe to let you know when there are other Dr. Manny Learnshops being uploaded. Thank you, and God bless.